Israel Berger, who completed his PhD at the University of Roehampton in London at the Centre for Research on Communication, Emotion and Interaction, which for the acronym lovers amongst us comes out as CRIKE. His research addresses a range of health communication topics at the levels of public health and individual clinical encounters, including silence, gesture, institutional structure and clinical communication with people from intersex, trans and gender diverse backgrounds. And Israel is currently studying medicine at the University of Sydney, in addition to independent research consultancy. Welcome, Israel.
Thank you, Sally. Can everybody hear me? Am I close enough to the mic? Closer? Okay. Effective healthcare communication. I am going to go through these points today, and I'm hoping to do about a 20-minute presentation and 10 minutes for discussion, questions, etc. So the goals of clinical communication, problems in communicating, the systematic structures and communication, designing structures that work, so pathways, and facilitating good communication. Now, the goals of clinical communication in particular, we've got more patient-focused goals as well as more physician or professional focused goals. And the main thing with regard to patients is we want to maintain dignity and safety, and that goes back to the first do no harm principle of medicine and healthcare in general. And so some of the benefits in clinical practice is that the clinicians get the accurate patient information. They've got the right patient. It happens. And so they've got the right patient, they've got the right medication, they know what people are allergic to, etc. They don't end up prescribing things that are going to interact with other medications, and they are able to maintain confidentiality. So if you think somebody is somebody else, then you might tell somebody's medical information to the wrong person, and things like that. And also being clear about, okay, can I talk to your mother about this? Can I talk to your partner about this? Without good communication, there can be some mess-ups. And finally, with reducing distress to the patient. So if you're not communicating that you're going to do something, if you're going to examine someone, then people are going to be like, oh, why are you touching me? So that sort of thing. And for personal benefits for healthcare providers, good communication means efficient referring. It's going to cost less in the long run to the system, to the hospital, or to the state or Commonwealth. And it also helps reduce the possibility of medical negligence claims. So you might not get sued if you're a good communicator. There's actually research out of the US, I think maybe Harvard, where they looked at medical negligence claims, malpractice claims, and it was quite often, I'd be okay with what they did if they had told me about it, if they had been nice to me, etc. People make mistakes, but they hid it from me. They didn't have good bedside manner, so they end up getting sued. So there can be a lot of possibilities for problems to happen in communication. These can be malicious problems, or they can be benevolent problems. So malicious things, homophobia, transphobia, racism, etc. These are intentional, hateful, and they're usually overt discrimination. More benevolent forms of discrimination, they can be accidental or unrecognized as problematic. Paternalism is another example of benevolent discrimination. So the doctor decides, I know what's best for you, and you can have avoidance of the issue or over engagement with the issue. So if if somebody comes in and they've got a cold and you start asking them about how they identify, etc., etc., might not be relevant to them right at this moment. They want to get rid of their runny nose, and avoiding the issue, being uncomfortable talking about it, and things like that. So communicating that you don't really want to engage with them. And this kind of goes also with cultural competency and cultural safety issues. And if trainings are great, and this is where people can start to learn how to interact with people. But training isn't always the only thing that can be done. And talking to people and getting those networks and understanding and becoming comfortable is the long-term goal of cultural safety and cultural competency. So by structure, I'm talking about systems and pathways and things like that. And in Australia, we've got Medicare and we've got private. And within that, we have hospital systems and we have GP practices and we have private clinicians who are also in the public system, etc. And how these are arranged and navigated for individual patients. So we quite often have assumptions about what the structure is, and quite often those assumptions might not actually be all that accurate. So the health system is constantly changing, and it's in many places the particular structures are actually quite informal. And what wasn't possible last week even might be possible now. So we had the example of the having to go through the family court to get hormone blockers, and last week that was the case, but now we don't. And being able to say, oh, I don't know, let's see what we can do is key there. And also with the assumptions, what people say isn't possible might not actually be. There might be ways around things. And to manage these, we need to think creatively about what the limitations are and what we can do within the systems that we work in. And to try to involve the patient whenever possible. So I might not be able to, I might not be able to write this letter for your surgery because I'm not qualified to do that. But I'm going to refer you to this person who I know can, etc. Things like that. Or prescribing using a different item code than you would normally. And we've had some lovely work done recently with Medicare changing the possibility for item codes to be used with different genders. So now you can do a pelvic exam and pap smear for a guy who has male on his record. And with the issue of what are limitations, patients need to know what the limitations actually are, and they need to be communicated. It can't just be like, oh, I can't do that for you, come back next year. And we need to keep on top of the structures and advocate for patient groups and patients individually to say, okay, powers that be, this needs to change. And so key points to remember when we're thinking about designing structures that are going to work for people. First and foremost, they need to meet the patient's needs. And that needs to be both at a group level, as we are now, but also the individual patient, because people are not all the same. And as we heard from James on the video earlier, people's wants and needs can vary very vastly, even within a group that's perceived by many to be pretty homogenous. And so people might not want surgery, but they might want hormones, they might want surgery and no hormones, they might want nothing. Maybe they just want to get their flu vaccine. And the pathways that we create for people, they need to be easy to navigate. You can't have a pathway and nobody knows about it, or they think, oh, I've got to go here, when actually they've got to go here. And having that information in publicly available format. So on one website, there's a particular set of organisations out. If you're trying to get registered as a psychologist right now, it's quite difficult because the APA has one particular part of it, and then another organisation has another particular part of the process, and you've got to go to this website and that website and contact that person and that. But if we have one place where people can say, okay, I want to do this, and what do I have to do? I can see this flow chart, and I understand. And that works for people. And again, one size doesn't fit all, and maybe those pathways only need to be a little flexible. So I was talking already about clarity in designing pathways and describing them, having one central place to find all the information people need. The pathway needs to be publicly available. People need to be able to cite it and say, well, I did this, so I should be able to do A, B, and C. And I want to go, the C route. The visual representation is quite good. I was talking about a flow chart. Verbal and textual communication is great, but that doesn't work for everybody. English might be a third language, and we have lots of people who don't read English very well. And so having a picture that says, okay, I understand that, maybe with pictures even in the flowchart. So just some ideas to think about. And you can have a website and everything, but if clinicians don't know about it, they're not going to seek it out. So you might think about things like having brochures in GP practices for patients, and posters and things also. But for clinicians, you might send out a special brochure for clinicians to their practice for them to look at, or to keep in the tea room. And so, particularly for trans and intersex people, we need to think about GPs' offices, endocrinologists, urologists, therapists, even perhaps plastic surgeons it might be relevant for. And for patients, getting it out to support groups and social groups, and maybe websites that people frequent. So there are a few websites, like OII's website, or FTM Australia, or I don't know all of them, but thinking about where we might try to put things and get things out there. And I talked previously about having posters. Posters are great. People don't always read brochures, but they see a big poster on them and I'd like to know more about that. And going into the individual communication, so between patients and providers, we need to think about both verbal and non-verbal things. And so if you look aloof, then people aren't going to think you're very interested. If you talk about somebody's body parts the way they don't want to, they might not come back, and things like that. So it's not just one thing, and it's a continually evolving issue and system that people have to make for themselves. And when we don't know, we need need to ask. And we need to make sure that patients feel involved in their care. We might think that, oh, I'm doing a patient-centered thing, I ask them how their day was. But that might not be really what they want to tell you. And to make sure that people actually feel involved in the treatment decisions and whether they agree with particular diagnoses. So we're talking about with you saying gender dysphoria as a diagnosis when necessary for centering, but we might not want to apply that to everybody all the time, because it's not actually benefiting anyone. And we need to use the patient's language and their concepts, and this isn't just with regard to terminology for trans and intersex things, but with maybe somebody says their arm instead of their humerus, and it's discussing body parts, discussing diseases, and somebody wants to say, oh, I've got heartburn. Maybe that's not the exact diagnosis. We need to relate to people how they understand their own bodies. And with that, speaking at their own level and their own knowledge. So we don't go into these big technical shoes when people aren't really going to understand that. But at the same time, we don't want people to go around to other clinicians misunderstanding what's wrong with them, because then the other clinicians aren't going to treat them like they know anything. So I've done a bit of work in various communication areas with regard to clinical encounters, and so if somebody comes to one doctor and they say, oh, I've got this bone cancer, but 10 years ago I had breast cancer, and they think it's a different thing, and we know as clinicians, well, maybe it's spread and we just didn't know about it. We're going to relate to them a bit differently than if somebody comes in with the technical names and says, oh, I had this and I had these treatments, and then it came back and now it's spread to my bones, blah, blah, blah. And so we just relate to people in different ways, depending on how they present themselves. And so if somebody is going around mispronouncing something or has a completely wrong diagnosis, then if we don't correct that, then we facilitate them not being treated as seriously by others. And with that, we can use pictures and diagrams to help people understand, even if they don't necessarily have the right words. And also writing things down, it's quite advocated nowadays, that somebody write it down, whether it's the clinician or a brother, sister, or a partner, or the patient themselves, just to make sure that we all have the same information, and next time we're still going to have the same information. So those are just some things to think about with regard to good, effective health communication. And I think I'll leave it there and open up for discussion.
Thanks, Israel. Well, questions, comments? Will you say that? Crunch?
Can I start with what role you think social media and technology are having in health communication?
Well, people have a lot more opportunities to go learn for themselves about their condition, and actually people with particular medical conditions quite often know more about what's going on for them than the doctor, particularly if the doctor doesn't see people with that particular condition a lot, or if they don't have time to keep up with what are the latest studies that are happening. You get about 400 studies a week in your inbox if you are really trying to keep up with just one particular thing. So people don't have the time to go and study everything that's right now current all the time. And patients, they do. They have the resources to go and to learn about that one particular thing that's wrong with them.
What about as tools of treatment?
What do you mean?
Like using, social media apps, things like that, to treat conditions or information given through, particularly for youth, I guess.
I think information dissemination is important in all regards, and whatever way people are going to use, that's absolutely valid and good. I was working on a project where we were talking about doing an app for helping people to make better choices with their nutrition and what they're buying from the supermarket. And one of the ideas was that when you're on your when you have your phone with you and you get near the supermarket, it dings and says, "Oh, remember to go low fat today," or whatever. So that sort of thing that could be quite helpful.
Is it acceptable to go into to see a clinician and ask to record we all have phones to actually record a conversation? Is that an acceptable practice?
I would say most of the time, probably. People are not always comfortable at first with being recorded, but that's not it's not particular to the medical consultation, I would say. And actually a lot of my research has involved recording consultations of various types. And after a few minutes, they think it's there and go on with things. I think that if they feel antagonised, then they might not want to. But if it's like, oh, I'm not going to remember what happened if I don't record, then I think that most people would be quite willing for that to happen.
In terms of distribution of publications to healthcare professionals and GPs and stuff, obviously there's a lot of healthcare professionals out there, and it's quite costly and quite complicated to do that effectively. And our organisation gets contacted by these third-party private information distribution places that many doctors look into to get online fact sheets and stuff like that, but they're all paid services. Just wondering if anyone has any experience of using those paid services and how effective they think they are, if they get any knockback.
A brief comment from me, and then maybe others have responses as well. One thing to think about with sending things to clinicians is that they're not the ones who initially open their mail. And so if the receptionist is just like, oh, that's junk mail, it's going in the trash. But if you're sending it to somebody who that's kind of their specialty, then they'll absolutely be interested in it. Whereas if you're just sending a generic thing out, then a specialist might be like, oh, that doesn't apply to me. Anybody?
Yeah, I'm wondering about the Better Health channel actually. That's certainly got an app link to it now, and it's the most heavily used site in the world. And I think it is geared towards consumers, but it's very heavily used by service providers. So I know a lot of GPs will go there as a first point of call to download information to give out to someone in a GP session, for example. So I wonder about that kind of opportunity for information about, referrals and facts and updating people's information about what's possible and what changes have happened that GPs might not know about, for example.
Yeah, I think that's a really good idea, and actually most of the time when you're looking for a health thing on Google, it's one of the first ones that come up. And yeah, as you were saying, it's most widely accessed, and I think that would be a really good option.
Yeah.
Liz? Communication issue or anything forward through? Yeah.
Just in terms of like you're talking about, I wonder if you looked at kind of environmental communication, this is quite specific, but in terms of how the consulting room is set up, and like for example, an experience I had was I went in and the doctor clearly had a crucifix on his desk, and I felt I couldn't, as a lesbian woman, for some reason I saw that as a barrier for me, and I didn't go back. So, and then just like not necessarily in this environment, in a past workplace, we had a poster up about sexual abuse, and one of the young producers in the homeless sector was very traumatised just by having that poster. So I'm just wondering if you looked at those kind of environmental, what you communicate environmentally.
Yeah, there's actually quite a bit of research on where people sit in a consultation.
Yeah.
That's a big one.
And
So,
what's in there? What's in there?
I'm not quite sure if there's much research on the posters and things like that, but in terms of how people are positioned and distractions and things like that, there's quite a bit of research, and sitting across from the desk is bad. No, don't do it. And sitting one person here, the desk here, and then patient here, that's a bit better, but it's not that great. It's what most people do though.
And the types of chairs, is that kind of power involved?
Yeah.
A shitty chair when you're the
Yeah.
patient.
Yeah, the chair thing is been studied as well.
It's not much for my conclusions.
I'll just throw in a quick one of my own there. Having been up to Canberra's Gender Centre, although it's not necessarily medical, the great sort of trans and gender diverse posters on the wall. I just walked in and felt so home there. So could be having something like, I can't think of examples off the top of my head, but just something that would demonstrate that. There's lots of stuff on the net that perhaps might be good to have a look at. Or, I don't know, the gender bread band, people have seen that. Those sorts of things would be really good. More?
Well, having like those stickers like safe space or I don't know what's in Victoria, but showing that, hey, you're aware that there are issues, you're friendly to these populations, those I think can help quite a bit. Just to make people feel comfortable.
I'm just wondering whether on like online forums and such, whether people celebrate or acknowledge whether they see good practice, whether that's something that you do and something that could be encouraged. When it comes to a doctor that sort of provides a good service as a communicator, is it something that happens within the community on an online?
I think that with the intersex community, for lack of a better word, it's more informal, but there are lots of lists for trans people there are lists that people have, and I think they're ones that you have to email to get because they're updated and they don't want outdated ones going out. But they're certainly there and quite large.